Thank you for joining us in this 60 minutes discussion about Reset 2021, organized by the Health Management Association. I'm Alexandre Lourenço. I come from Portugal, and I'll be moderating this, and I'm quite privileged to moderate this session with such an amazing panel. We will have a brief presentation from each of our panelists, and I will start immediately with, and mostly to use our brief time to come with Davide Caramella. What worked, what failed, what comes now?
We are talking about how our hospitals reacted to the COVID-19 challenge, right? And in this perspective, I can say that the university hospital where I work was quite lucky, because in Italy, the first outbreak of the pandemics was in the northern regions. So Pisa, being the center, had time to prepare, and therefore, I would say that it mainly worked. What failed is that probably we overdid a little bit, particularly as far as radiology is concerned. We devoted a big chunk of our radiology resources to the COVID hospital, and that resulted in under serving other patients because a significant amount of radiological resources were, let's say, devoted for eventual needs of the COVID hospital. But as I said, that was a little bit overestimated, and therefore the resulting issue was that some patients with other problems other than COVID-19, they had to suffer a waiting list longer than usual. For the future, I think that the lesson learned probably will help us to cope with the next months in which the pandemics will be somehow influenced by the vaccination, which is going very well in our region. So I'm relatively confident.
Thank you, Davide. Immediately to Rafael Grossmann. You are muted.
Good morning. A pleasure to be here with all of you. I'm in the U.S., in the northeast of the U.S. in Maine, and I am originally from Venezuela. I think that what didn't work initially was certainly the communication, the connectivity between all the different players around the world. I think that whatever the message was originally for the pandemic, at least here in the U.S., I think that from my perspective as a clinician, as a full-time provider, I think that we were late to alert ourselves to fear this pandemic on the way that we should have. But very quickly after that, I probably say that we wasted a few weeks. I think that the amount of resources mobilized from getting ventilators ready and PPE equipment ready and changing the way we acted, the results of that were somewhat in certain areas effective. Obviously, the major metropolitan areas where most of the population lives, where most of the hospitals are as well, they were overwhelmed in a very rapid fashion and for a long time. I think that that should have been better, but I am not disappointed or frustrated with how the response picked up. I think that COVID offered a great opportunity indeed to communicate and connect better in a worldwide fashion, to crowdsource information, to organize from the big players to the smaller players, and certainly the degree of innovation that we saw and that we're still seeing in the pandemic, because of the pandemic, has been phenomenal. From vaccines development to development of PPEs and development of contact tracing applications to ventilators and ways to sterilize environments and so forth. Obviously, the upbringing of telecommunications, telemedicine, telehealth has been a very, very good positive response, and I think that that's one of the good things, of a few good things, that is going to stay to some degree in an adapted way after the pandemic, and it's probably one of the positive things about the pandemic.
Thank you, Rafael. I believe that you are quite positive. Let's see if Christina is also so positive about this last year. Please, Christian.
Thank you. I'm very honored to be in this panel. I will bring a very different perspective in the conversation. I'm not working in a hospital, but I will, of course, recognize the fabulous job which has been done by all the healthcare professionals in so many regions around the globe. I'm coming from the standardization side. That's my business for the last 30 years already. In this space, I would say the positive thing is that the toolboxes regarding medicinal products were ready. Nothing had to be invented in last minutes. We had, I would say, an architecture to capture information, to register information together with the regulator, the manufacturers, of course, the medicinal product dictionaries, etc. All this architecture is available, has been published a couple of years ago, not so long ago, but published. And on the supply chain side, because I'm very attached to the supply chain, I would say we were also ready. The toolbox is ready, actually, and I would say for North America, the DSCSA regulation already imposes a certain number of tools to be used to have a safer supply chain. And in Europe, we have a relatively similar system with the Falsified Medicine Directive. That means that we have another tool to protect ourselves against falsification. I would say diversion, but really falsification is a big issue at this moment. That is the positive. And now the negative. Where is the toolbox? In your tray. The toolboxes haven't been used so much, and it's a huge disappointment for me, and not only for me. When you look how the immunization process is running now, and I don't criticize anybody, I just say having to write by hand on a piece of paper the batch number from a vaccine is error-prone. It is proven that it will not be done without errors. And if we want to collect information from that, it will be a disaster. So we have the barcodes, but not so many are reading it. We have the architecture I was mentioning before, which is not limited, absolutely not limited to vaccine, to, I would say, support adverse event reporting. And I don't think it is so much used at this point of time. So it's a bit of disappointment. Mm.
No, thank you, Christian, for your input. John Nosta, what is your perspective?
Well, I'm going to be the strategist in the group here. And I think that COVID has shined a light on good things and on bad things in clinical practice and pharmaceutical drug development. But I want to try to focus that on what I think is really the essential observation of the day. And as we look to clinical care, as we look to the evolution of the virus, I think all eyes are on one thing. And I'm going to go out on a limb and say this, but I think all eyes are looking at the mutation of the virus. That as we expand our acumen in clinical practice, as we look at the wonderful success of the vaccine, we still look at that spike protein. You know, we scratch our chin, we say, what's going on? What's going to happen if this mutates to a more virulent strain? Or other things happen. And to me, that's the defining element of COVID. COVID introduced to our world the need for agility. And it's not only clinical agility. Do you flop the patient on their belly? Do you use a respirator? How do I make sense of the ambiguities of hydroxychloroquine? These things are so important that we have to have that sense of agility, both functional agility and intellectual agility. So for me, that was really a defining element. Now, that's the good news. The bad news is if we want to be agile, if we want to know what we're changing to and planning for, what is the next emergency? And it very well may be mutations in the spike protein, but it might be something completely unrelated. The next natural disaster or the next clinical emergency may be about water purification. It may be about iodine supplies for a radiation emergency. How are our iodine stockpiles? Everybody's concerned about PPE and it's all stocked now in some instances. So for us, we need to have the intellectual and functional agility, and that's largely mediated by technology. We need to be connected. We need to build a platform where we can think fast, act fast, and solve fast. So for me, COVID has been a bit of an inflection point. We talk about that a lot. We talk about this inflection point in technology where things are changing rapidly. And I believe that is the case. The question is, how can we capitalize on that to build a path forward for the next disaster, which will have nothing to do with COVID, sadly, or happily.
Actually, healthcare is not, well, it's not for incremental changes or innovations, but not quite for this kind of leapfrog innovations.
I'm gonna jump in. When I was learning medicine, and Rafael will probably agree with me here, I wanted a better cephalosporin. I wanted a beta-lactam that had an increased spectrum of coverage, maybe a little bit better GI tolerability, but I didn't want anything too out there. Even the concept of a gyrase inhibitor and a quinolone kind of frightened people in the early days. So I think that clinicians, because being safe and thinking things through is very, very important, many of them want the same but better. Nobody wants a nuclear-powered heater for their house. They want a gas heater because they know that technology. And I think that's the same with medicine. And that's a blessing and a curse. It's that duality of wonder and fear that I think is a bit of an obstacle, but it defines the field in which we work.
Yeah, that's that need for having to be safe because we are dealing with human lives. Rafael, what's your perspective?
Hi everyone, I'm very happy to be invited to this panel, and from my view, I think it's the weird discovering what is telemedicine at the end, because it was there but we were not using that. It was with us, but we know some things to do with that, but not the real experience. And I think we jump on that, but we were not prepared. We thought that we have the right tools, but probably they are not the right tools, because we have to deal maybe with elderly patients that are not ready to deal with that, and then you have to face with that. Many of the office consultations went through telephone, and I think it's too poor. So probably we need more improvement on that kind of technology when you cannot deal with the patients directly. That is a problem, I think. But we discovered the need of the telemedicine, but a good telemedicine that we don't have in this moment. So I think it was a push for getting something better, this pandemic at the end. But it was there from the last 30 years, but probably some experience. That's one of the main things from the pandemic. Other point, I think, is the integration of these tools on electronic health records, that it's something that is needed, but it's not easy to do, because always these electronic health records are things that are very close. So you can introduce new things there is very difficult in a short time. This is another thing. In Europe, I think it depends on which country you live. I think, for example, we have apps for tracing contacts, but for example, the experience in Spain is not so good, because at the end you have that, but it's not installed. Or if it's installed, you don't give the alerts to the patient to say, I am a patient, where are my contacts? So there is not a good strategy to apply these tracing apps, at least I don't know if in whole Europe, but at least in my country, I have to say that the strategy was a failure. That's something that in other countries is working well in Asia. In Europe, it's not like this. And I think the next step for this 2021, I think the main challenge is how to deliver vaccines in a fast and proper way. I think in Europe we are getting a little bit behind if you compare with other areas of the world. it's a big strategy, whole Europe, you have to distribute to everyone, but I think we feel that it's something slow. When you are getting your vaccine, it's something that, maybe it's not working with the South African variation. So it seems that it goes very, very slow. I think it's one of the big challenges for us. This is my view, better telemedicine and better vaccine rollout.
No, thank you, Rafael. I go immediately to Robert, but before that, I would engage also with our audience. You can put your questions on the Q&A box that you can find below part of your monitor. Robert, what is your perspective?
Good afternoon. I'm a general practitioner from Belgium and a clinical pharmacologist. And especially with the perspective from Belgium, the pandemic hit very hard in our vulnerable elderly and in the long-term facilities. And we have 2/3 of the deaths in the first wave were there. They were cared for by unprotected personnel and personnel that was not prepared for the heavy ethical decisions they had to make in this terrible situation. So, and we had to come also to observe that we knew so little from these elderly. It was already hard to count the deaths, but let alone that we know what were the diseases, what was their risk profile. We had to observe that the digitalization of the medical documentation in this sector of healthcare was extremely poor. And I think if it's one lesson learned, this is something we really need to remediate. The second point is then that after the pandemic, and now that a never seen vaccination program is coming up with 200 vaccines in development, in most countries already 5 on the market, beginning first with the very centralized cold chain distribution, and then gradually spreading out to other forms of distribution and of several different vaccines through hospitals, to factories, through the GPs and the pharmacies. How will we know who got which vaccine when? How is that recorded? What is the digitalization of the Immunization Act? It is so easy to do so. If the vaccines carry barcodes, the doctor or the vaccinator can, in a few seconds, digitally record the identity of the vaccine, the identity of the patient, his own identity, and send a full message, structured message to the eHealth infrastructure. And from there, you can warn the immunization registry, you can make the certificates, etc. But we must be sure that the recording of the Vaccination Act is correct and done in an interoperable way. And I'm afraid the distribution, but also the recording of the distribution, will run into chaos soon. And we need to remediate that. The quality of the documentation of the Vaccination Act needs to be much better than today. That's my point.
No, thank you, Robert. Actually, I believe that is quite common to all of our panelists, that we have the tools, we have the digital tools. They were there before the crisis. And my question is, why aren't we using it? It's a matter of literacy, of strategy, of implementation. Christian, do you want to come in on this?
Thank you. It's a tricky question, you know. I think IT in the healthcare industry is underestimated. And if you compare the investments for IT in the healthcare systems in a hospital or in a region, compare that to what the banks are doing, we are bonsai. This is a big problem. And I don't want to open polemics, but you know, when we have the tools, and I think Rafael spoke about, we are practicing telemedicine, but we found some limitations somewhere. That's interoperability. That's the tool which the standards are supposed to cure, you know, to help to implement properly, etc. So In my perception, one of the big issues we are facing is this lack of visionary program or ambition to make healthcare safer. And look what happens now regarding cybersecurity. We seldom hear that exists, but we seldom hear cybersecurity issues with banks, but we have issues in the healthcare systems. On a positive note, I would say that this crisis probably has opened the eyes of the people, and maybe the strategies will evolve and take more consideration for the IT investments and the standards implementations.
No, thank you. In the world that we discuss precision medicine, big data, artificial intelligence, we can't register vaccines. John, you raise your hand.
Yes, I want to talk a little bit about telemedicine because I think that's a fascinating area. And certainly fintech is a wonderful opportunity for us to learn. Picasso said that good artists borrow and great artists steal. I think that clinicians should use that line a little bit. But my observation of telemedicine is that it's transferring a Zoom call to an office visit. And that, to me, that's a little sad, because if you look back at the early days of developing a website, we created something that was very flat and boring, but ultimately people got a little bit more educated, and they created what's referred to as the user experience, the US. And that UX can be translated to the clinical experience so that we can use different modalities. We can make it telemedicine 2.0 and 3.0, where we could use the AliveCor EKG, a single lead EKG for rhythm abnormalities or atrial fibrillation. We can use an echo stethoscope now that the patient uses that transmits heart sounds, that looks at pulse tracings and does a rudimentary pulse tracing that looks at contractility. So for me, I think that we can't just translate telemedicine that simply. We have to advance it and make it more robust and more engaging. And I think that's the challenge before us now.
Yeah. Thank you, John. Rafael, you want to come in?
Yeah, no, briefly, I think that echoing what Christian was saying, I think that we had tremendous failures in leadership, okay, at the big level and at the local level in many instances. And we also had a tremendous failure on innovation. You know, we certainly have the digital tools, and you know, if we book a ticket on a to fly, we can do that in 2 seconds in our smartphones, but at the same time, those technologies did not translate. And I think that leadership and IT is the second one. IT, you know, we have very advanced IT systems in the hospitals, at least in the US we do. But what happens is that the IT is 99% focused on the wrong doing of digital health, I call it, because it's just all about, you know, billing and documentation, and do not even look at the patient, the human patient, just look at the computer, look at the EMR, the EHR, and that is probably one of the issues. We were caught off guard, and despite having disaster plans and very few drills, you know, over the years, we could never imagine that something like this was happening to a level to be prepared with all the tools that we had for fighting something like this in an effective and efficient way.
No, thank you, Rafael. For the other Rafael?
Yes, I want to highlight, I think I agree a lot with Christian. One big problem is interoperability of the electronic health records. I could give the example of my country. We have 17 regions, so each one has a different electronic health record solution, and it's in the same country. So I imagine that in the States of US, it happened more or less the same. So I think we have tools, but we are not able to put it together to a greater solution. It's like it's also another person speak about vaccination. There are countries, they show that they are writing a paper, what vaccine you get, what box is your vaccine. I think it's probably in this century, we could do it better and more digital to have more tracing of what we are doing. But the thing is where you pack this, because if your system is not compatible with the other one, we are making an effort of digitalization, but it's lost because it has not the reach of a bigger thing, because you are in your small place and you don't pass the data to your neighbor. So it's something complex. If we think in European Union, probably it happened the same. I don't know. So probably there is not so much connection between countries. That's a big problem, I think.
No, that's an issue. We have been discussing this digitalization process for some years ago. It's not something new. You know about this much than I do. But actually, it's quite odd that at this point we are not able to implement this kind of tools in a moment of a real crisis and where we would need it. I'm quite surprised by what Robert was mentioning, mostly mentioning the issues related to the vaccination process, and this is mostly related with the next months that we have ahead. Robert, what can we do to promote this digitalization of the vaccination process that actually should be the main strategy of most of the health policymakers?
First, I think the pharmaceutical companies who had to market the two first vaccines were faced with mass production and mass distribution, and completely asked for exemptions of the normal labeling procedures. There were pizza boxes of 195 multi-dose vials shipped without information, without proper recognition on the vials, and certainly not facilitating this at the point of care documentation. I hope with the new vaccines, and certainly the ones that Johnson & Johnson is shipping, I've seen that there are data metrics on every vial, and that will change from a very practical point of view the easiness with which we can record the Vaccination Act. And in the beginning, this has completely been overlooked, and companies were exempted of doing. They had to produce the vaccine in very big boxes, but not care about the detail of the identification, which goes also with the problem of falsification, the control for falsification. Now it's in the beginning, it's maybe not really important because everything is going to very centralized distribution channels who are heavily checked and controlled. But very soon we'll have a lot of other distribution channels, and I think fraud and falsification will come up also in the rich countries, certainly already in the developing countries where the need is higher. Every nation now is struggling to get his population vaccinated as quickly as possible. In 3 or 4 months, we will be in the situation that the rich countries have 4 or 5 times the vaccines that they need. And then we can start talking about equity. This pandemic will not go away if not every country has reached herd immunity. So it's in our interest to make sure that equity in the vaccination is at the forefront of what we do. Now it's difficult in this startup period. Everybody is complaining that it's not going fast enough in each country of the rich ones. We don't even know that.
That's a relevant topic. Robert, let me just go a little bit back. We are not discussing a digital passport for Europe, for allowing the movement between countries. The issue, I don't know, Christian, if you want to come in on this, we are discussing the registration process that it is not quite accurate. And we are taking a further step to have these digital passports for the ones that are vaccinated, mostly to relieve them from quarantine periods in some European countries. What can we do about this? What are the steps that we really need to have a coherent and safe process on the vaccination, and mostly with this idea of linkage with digitalization?
You asked me the question, right?
Yeah.
I'm very close to Robert actually, because when we look at the full picture, from my left, it starts by the manufacturing, and things have to go right at the manufacturing. Of course, quality of the medicinal product, the vaccine, whatever, its labeling, and a sequence of process, marketing authorization, etc. And at the very end, you have the outcome of all that. The outcome is the patient. The patient has an adverse event or not. How can we retrieve the information, etc. That's something which must be coherent. And this is the plaidoyer we have, Robert and myself. And we are practicing this in Europe in the Unicom project. It is a European Union funded project having the purpose to foster the implementation of those standards I mentioned as a toolbox before. In the US, you have also some activities around that together with the FDA, but in Europe, it was a bit slow, and Europe is more fragmented. So this project has the purpose to bring the authorities, but not only the regulator, but also those e-health authorities, of course, but also those supporting the prescription, etc., to use a coherent we say system of identifiers, so that when we speak about something, it is, I would say, globally understood the same way. Why do I say that? It is because there are, cost factors. If we can agree on a common language in the supply chain, the data supply chain for medicinal products, we are going to gain in efficiencies, because we will be much better in position to aggregate this information, develop intelligence, better understand what happens, what is good, what is less good, and so. And my plaidoyer is the tools are there, and I think, it's my belief, I think the stakeholders will start to understand the value of the standards, bridging interoperability, etc. We try also to work with the WHO, headquarters. It's difficult because, many people think they have a better standard than the standard.
Yeah, thank you, Christian. Let's just brief a little bit to end this point about the digital and the vaccines, and let's go to another topic. But John, you want to comment on the...
Just real quickly, I'm fascinated by the word digital that is in almost everyone's lexicon these days. And I think that's the linchpin to the evolution of advancement of many areas in life and in medicine. That digitization leads to the dematerialization, which leads to the demonetization, which leads through disruption to democratization. So I think that digitization is very, very important. And just to echo what the group has been saying, oftentimes it's not innovation, but implementation. Many of these methodologies are well established and here today, and it can be said for vaccine distribution and tracking as well as telemedicine. So in many instances, we're not seeking a new innovation, but we're just trying to get an innovation accepted. I think that's an important dynamic.
No, very, very relevant, John. Let's go to our Q&A box. One of our attendees is mostly asking us about management and healthcare management. I don't know who wants to come in on this. Do you see a space for improvement? Or for my side, at least, I see that we need improvement of healthcare management. Davide, you want to come in?
This is a very interesting question. I can offer you the description of what happened in Italy. In particular, in northern Italy, the hospitals, they asked a lot for advice from economic advisor. And oddly enough, if seen now with the perspective of what happened in the next few months, since several years, these economical experts, so-called, they gave the advice to save on intensive care units, because intensive care units are very expensive. And so there was, let's say, an effective reduction in the investment in intensive care units, and that resulted really very, very problematic during the peak of the pandemic that, as I said, took place in our country, particularly in the northern and more rich regions. So there was this paradox that the most rich regions were also the comparatively less prepared to accept so many patients in the intensive care unit. And this also echoes a little bit what was already said in this panel about information technology. Information technology is everywhere in the healthcare system, but probably is doing the wrong things, is not doing what is really most needed for the patients. So I think that management has to rethink, one, where to make all the relevant investments, and also how to make a good use of the investments that are made. Otherwise, we risk to be unprepared when a next emergency will require all our efficiency.
No, thank you, Davide. And actually, there are very, very good points. I believe that also Robert was mentioning the issue about aging and the preparedness for all the challenges that we have on the healthcare. The issue here is the healthcare management component in the system. Did it work well, or what do we need to improve it for the next years? Because we know that we need to be much more flexible than we are. We need to be more agile. We need to respond to our patient needs. I believe that we can agree that we are not supplying probably the healthcare that our population needs. What can we do better? What can we improve on the next few years? Who wants to come in on this? Rafael Grossmann.
Yeah, I think that there is absolutely much room for improvement of the healthcare management. Obviously, it's not universal. You know, there are certain areas that responded and are still responding very well. But I think that to have a healthcare system administration locally, I mean, that is definitely more dynamic and more versatile and flexible, with better allocation of resources, with true innovation, not innovation about getting a digital thermometer and scanning everyone who comes into the hospital. I'm talking true innovation from the process, from idea to implementation and impact of that idea. I think that that's very important. And what is a very, very paramount issue is that healthcare organizations need to think about patients and about healthcare providers, employers. We have seen a shameful, a frustrating reaction of the healthcare administrations towards employers, and I think that is impossible to justify. People working in the trenches without a proper equipment, without the tools that they need in order to even protect their patients. I think that has been very, very shameful.
Well, that's the minimum that we need to comply. I'm mostly asking, what do we need to come from that? So I hope that everyone agrees that at that point we need to achieve at least to have PPEs for everyone. Robert, do you want to?
Yeah, I think you spoke about that that healthcare management need to respond to the needs of patients better, but we also have to know the needs better, their expectations and their wishes for end of life decisions, etc. Our elderly people are with lots of comorbidities. They will be the victims for the next pandemic, the victim of pollution accidents, of whatever, of all the big catastrophes. And our management system and the personnel in our management system is simply not equipped yet to face these kind of things. And I think the ethical aspect of advanced care planning must be much increased and stressed to be ready for the next catastrophe, I think, because this has painfully failed, and I think it was a personal drama for many healthcare providers making difficult decisions.
Thank you, Robert. The issue about the local and to have this flexibility to develop this kind of local partnerships and to be open to develop this kind of local partnerships that actually we have very centralized systems still. And actually at the local side, sometimes we don't have this kind of view or vision to implement it that can be quite relevant. Rafael Vidal?
Yes, I think from the point of the management, I think one key point in our country was that, how to say, we have all the regional systems working separately, and we went together due to the pandemic. And the problem is that the central organization was not ready to organize the local, because the locals were working a lot of time by their own, and they're working well. So I'm trying to re-centralize. At the end, it was like an error how to deal with that, because they were more ready to buy the PPEs and other things. So I think the local management, it's essential. Many solutions, good solutions, came from local ideas, not from their central system. And another point, I think it's how to, in the management, I think good solutions came because the managers of the hospitals listened to the clinicians on how to organize this, because it was like not so from the top, the organization, it was speaking with the chiefs of the departments, and the things went a little bit better, I think, not through the administrators, more than from the clinical arena, to how to organize the ICUs and things. I think the deal of the role of the medical, the healthcare professional, I think it was essential.
No, thank you, Rafael. But that's the principle about innovation. You shouldn't have it on the local side, and mostly to have this kind of bottom-up process where we have at least open innovation systems implemented. Christian, you want to come in?
Yes, I was enjoying what John was saying about innovation. It's sometimes a question of interpretation or semantic. What is innovation actually? Is a smartphone innovation? Maybe yes, maybe not. And the trouble is sometimes people who are, thinking to embrace innovation as, a strategy, a way to go. These people think that the innovation is something which did not exist yesterday morning. Innovation is not that, because things don't evolve at that speed. Innovation sometimes is 10 years old and not implemented. So the fruits of that innovation hasn't been really seen on the ground. And I think we haven't explored, to its ends, process innovation by using technologies. I think at barcode scanning, for instance, in hospitals, down to the point of care. We haven't explored that to its ends. There is a lot of space of improvement there. But is that innovation? For me, yes. But it doesn't sound so sexy than implementing radio frequency and very complicated things, which bring actually very little more than proven technologies. And that's, innovation is the way you will implement an existing technology to be very efficient, secure the proper care, and at the end save lives, etc. I mean, that we have a potential there which is not explored, and I think we should really work on that. And this is my, again, my belief. I'm very optimistic. I think this pandemic has revealed a certain number of issues. Think at shortage. We had shortages in various spaces, but that was not exactly shortage, just the product were not at the right place. So we have something to learn from there and work better. And that's also innovation.
No, thank you, Christian. The issue mostly is that when we are talking about the innovation in the healthcare sector, we must realize that probably our system is for the last 70 years is mostly the same. The way that we are organized, our providers. So, and actually we resist. I believe that John was mentioning that one of the issues is to be safe, but there are lots of to do. And what we probably learned from the last year is that actually we are more agile than we expected to be. More agile, but also, and it was mentioned previously, is that actually we redirected our resources to COVID. And we have still our patients and their needs are still there, and they are not being dealt with. John?
I agree with the comments. I think that complacency in the medical system is endemic when you look at the hierarchy of hospital rounds, of the power of the chief of medicine, and that's the way it's been done, that can be oppressive. You know, I think that we need to recognize that playing it safe can be a very risky strategy because patients can die. And we saw that in COVID. So playing it safe is not the option. Now the flip side to that, and most innovators talk about this, and people who study innovation talk about failing fast, right? The notion of agility and failing fast. Well, I mean, failing fast in a clinical construct is a catastrophe, is horrible. We don't have that luxury. So we have to fail smart. And failing smart is a little bit more difficult because that's what Einstein told us. That's the thought experiment. That's pushing the bounds of clinical practice in an environment that may be safer because it's cognitive. So we have to begin to think about barcodes. You know, we have to think about the implementation of existing things. I mean, we all remember drawing arterial blood gases, right? And sticking the radial artery and that big bag of ice, and we'd run to the lab. You know, those days, then pulse oximetry came along and it changed the game. And sometimes innovation is like that, but sometimes innovation is a little bit more sneaky. But I think that it's much, as you think, so you act, as you act, so you become. You've got to embrace innovation, at least from a cognitive perspective, to do that thought exercise, to do that Einstein type of experiment and think about what possibly could be.
Now, even though barcodes started in '74 from the last century, and we are talking in 2021 about the implementation of barcodes. So that's a little bit short. So when do we expect to have real implications about artificial intelligence, for example? And there was a very nice push during the pandemic, even for diagnosis. And it was...
Yeah, I'm going to jump in because you said those two magic letters, and then I'll quiet down a little bit. But artificial intelligence, you know, is spooky. Artificial intelligence is frightening. Artificial intelligence is put in a position where we say, will it replace the lawyer, the doctor, the Indian chief, whomever? But I think that we've seen in medicine the nature of collaborative care, where stakeholders are important. I need to listen to the patient. I need to listen to the caregiver. I need to listen to the engineer in an innovation construct. But I think we're seeing now that technology is going to become a partner in care, that they demand a seat at that table. And what that will do, it's going to shift some of the cognitive heavy lifting away from the clinician, because we know that the clinician is oftentimes the smartest person in the room. That's the doctor. They know the answers. But information is coming at us so quickly that humans cannot assimilate that data, new clinical trials, new published data. So we need to look to AI and artificial, you know, and technology to share the burden, to do some of the cognitive heavy lifting. And I think that's going to be a fundamental change in clinical practice over the next few years.
No, and then this movement from the clinician know best, I'll probably to the patients also as his word. Let me just go a little bit back in our Q&A box. There is a very, very nice question that I want to have your perspective. When can we hug and leave our masks behind? Who wants to come in on this? I believe that from Nordic countries, probably it's their life. From Southern countries, it's something that we really miss. Who wants to come in on this?
I can comment on that.
Yeah, come on, Rafael. Thank you.
You know, as a clinician, again, and living in the U.S., my perspective can be obviously very different from someone who lives in a different continent or in a country with different, income per capita. But I think that we still have a long, long way ahead of us. People, looks at the vaccination rates and it's good. Now we're good. Now we're safe. And let's get a digital passport, and then you can get your stamps, and then you can travel. And then, that is completely nonsense, because even the vaccine, you do not know what happens. I mean, you don't get as sick with the vaccine, but doesn't mean that you don't infect people as well as we did before the vaccine. So I think that the risk is that we jump too quickly into dropping our guard. We need to be vigilant. We need to keep our eyes open, and we need to use all the resources in order to to really not repeat the same process that we've been doing. Oh, this is the first round. This is the second round. This is the third. It's all the same, if you ask me, because patients don't know if they got the first or the second or the third hit of the pandemic. I think that we are in the same long process of this pandemic, and the mistake is thinking that things are better. Let's reopen. Oh no, let's close. Let's partially open. Let's have the restaurant, but you eat outside. I mean, you have 100 people eating outside the restaurant, all close to each other. So it doesn't make any sense. And it's a very complex issue. But again, the message has to be, we cannot relax our guard, no matter what, if we want to really beat this.
No, thank you, Rafael. That's a very, very, very good point. Actually, we learn from, 100 years ago, we had the Spanish flu. We changed the way that we behaved mostly. We had actually during this century, we had a problem with microbial resistance. And actually it was something that was on the rise in our hospitals. Maybe with the COVID measures, we can say this, probably we have nosocomial infections under control, or at least better than we had previously. How much time do we have to assimilate these behaviors in our organizations, in our institutions? And how can we assure that this will be the standard for the long term, and not something that we will behave like this on the short term, or only for the short term, during we remember the COVID pandemic? Christian, do you want to come in?
Yeah, can I speak as a citizen, not in this space? What I think is very dangerous. It is that our authorities, they change the rules, not every day, but very quick. So you mentioned 100 people max, 5 people at home. These rules are very special. I think we are going to have a fundamental change in our behavior. I also did read that person asking, when can we hug again? I'm living in Switzerland, so not exactly south of Europe, but we like hugging people here as well. And we will probably not do that for, I don't know for how long. The problem is the change of the behavior that takes a long time. And that's the authorities are so diverse in the way they address, the right attitudes to protect the population, etc. Inside one country, they change their mind very quickly. But when you look at the countries, Switzerland, as you know, is with many countries around. The French do this, the Germans do that, the Swiss allow to ski, the Germans not. All that is so incoherent that the impact on the change of behavior by the people is difficult. I would strongly prefer that our governments, our stakeholders, have some modesty. It's not a question of the dictator saying how to do. Some modesty, and we stop to escalate, measures which we cannot control at the end.
Thank you, Christian. Let's go for a final comment. I will start with Rafael Vidal-Perez.
Well, I was wondering on this of the behavioral things that we were speaking. I think it's funny because in Spain we beat the virus on summer. Our president went out and said, "Oh, we beat the virus." So I think these attitudes, I think, don't help in any measures to take new measures when you see that the things are not how you think. So I think it will be complex. I think the vaccine, the people think that with vaccine everything is solved. Maybe we have to wait 1 year and we go back. That's the problem. I think is what is the people thinking, because probably the message of our government is not the right one. So it will be
Rafael,
a tricky thing.
Let me just interrupt you. In
Yes.
our organizations, in our institutions, at the hospitals, we change a lot also, our behavior. How can you stick with this behavior that actually is quite helpful for allowing us to provide quality of care?
Yes, I think we see it with the virus that we don't have the only virus that we have is COVID. That the other ones disappear. That is true.
Yeah,
I think it's the flu. What is the flu? It vanished.
No, and other nosocomial infections. Rafael Grossmann, final comment. You are muted.
Yeah, I think you nailed it. It's really it starts at home. I think that and it's very, very difficult. I think I'll stick with a message of we need good leadership, wise and flexible, agile, like John was saying, leadership. We need to do true innovation, and we cannot let the guard down. Like Christian was saying, up and down. One day one thing, the next day is a completely different thing. That is nonsense. We have to be scientific, and we need to again do not let the guard down yet until we know more.
No, thank you so much, Rafael. Robert, no comments.
Our behavioral change will also be in the way we meet in business, in science. And taking that physical crowd element out as a necessary driver for being productive will be very important. And I think the technology will help us. This is an example today.
No, thank you, Robert. Christian, final comments and message to take home.
Innovation. Safer care starts with a simple beep, the barcode. We can do a lot with this so simple innovation, because the systems must follow, of course, behind.
No, thank you, Christian. John.
I think that given the intrinsic frailty of humanity, the solution will not be societal. The solution will be scientific, and that will be driven largely by technology.
No, thank you, John. Thank you, all of you, for your great interventions. I also thank our audience. I believe that we nailed Reset 2021. I'm sure that 2021 will be much better than 2020. We need to stick with our compliance with the behavior measures. And I engage you also to continue to assist to these webinars organized by Health Management, and to continue to visit the websites and reading the Health Management, the journal. Thank you so much and see you next time.